title of this talk is Surveillance Imaging for Head and Neck Cancer, but the real point of the talk is to introduce the concept of NI-RADS and encourage everyone to start using NI-RADS in your clinical practice. If you think that this title is some sort of reference to Star Wars, you're right. In order to talk about surveillance, we should define what we mean by surveillance. We're talking about patients who have been definitively treated for head and neck squamous cell carcinoma. We're not talking about patients who are halfway through their treatment. That's monitoring the treatment response. We're not talking about patients who are in the palliative stage of their treatment. There's really we know that they have cancer and there's no point. Also, we're only talking about patients who have no clinical evidence of disease. Surveillance means we think clinically that there's no disease present, but we want to use radiology to be even more certain of that. Why do we bother with surveillance imaging? We want to be able to start treatment of recurrence earlier, before there's even clinical evidence of disease. We believe that by starting our treatments earlier, we reduce morbidity and reduce mortality in these patients. It's not proven scientifically, but we believe that to be the case. There are many different options for performing imaging surveillance in head and neck cancer patients. Ultrasound is used extensively, particularly outside the United States. Contrast-enhanced CT is the traditional default method within the United States. MRI can be used. It has some advantages, such as the use of perfusion and diffusion imaging and its whole body capability. PET-CT has become a default modality at most institutions. Exactly how it's used remains controversial, and we'll talk about that. At a few institutions, PET-MR has become available. It's useful in very specific situations, usually situations where you were going to do an MRI, say, of the skull base anyway, and you were going to do a PET-CT of the whole body. Well, you might as well go to one-stop shopping with PET-MR. So when do we perform surveillance scans after the conclusion of treatment? The National Comprehensive Cancer Network nominally has some guidelines. Unfortunately, they are worthless. The guidelines say that baseline imaging should be performed within 6 months and provide no greater guidance than that. These guidelines are outdated. They do not take into account the recent literature, particularly with regard to PET-CT, and they recommend imaging only for advanced stage tumors, which is probably appropriate. So I'll tell you something about what we do at the University of Pittsburgh. Our first scan is performed either 2 or 3 months, somewhere in that range, after the conclusion of therapy. We know that there's no disadvantage to doing it at 2 months versus 3 months. You get the same sensitivity and specificity. You don't want to do it earlier than 2 months because there's a strong risk of false positives for surgical patients because of the healing and the effects of radiation. And you don't want to do it later than 3 months because you may have lost an opportunity for cure. So then once you've done that initial scan, when do you do additional scans after that? Our default is every 3 months. This is pretty controversial, especially when it comes to PET-CT, which is a very expensive modality, and insurance is loath to pay for multiple PET-CTs. Should we be mixing in some different modalities? Should we be reserving PET-CT for difficult cases? These are unanswered questions. And then when do we stop? When do we conclude imaging surveillance? These patients will be getting physical examinations for the rest of their lives, but when do we stop using the more expensive imaging? Well, we know that contrast-enhanced CT scans will find 50% of eventual recurrences within the first year after therapy, and 75% of the recurrences within 2 years because of historical data. We know that PET-CT does much better. 75% of the eventual recurrences will be discovered in the first year and 95% of recurrences in 2 years if you use PET-CT as your surveillance modality. That's a lot of PET-CTs. It's expensive, but boy, does it work. So our recommendation at the University of Pittsburgh is to scan routinely, for us every 3 to 6 months, routinely for the first 2 years. And because we use PET-CT extensively, we know that we're going to get 95% of those recurrences found in those 2 years. Now, what if there was a way to be even more clever about how we employ surveillance imaging? Maybe the results of some imaging can be used to tailor the timing and modalities of future imaging. That would be a lot more nuanced than just we do it at 2 months and then every 3 months after that. So we know, for example, that if you have one negative PET-CT after the conclusion of your therapy, you're 90% likely to be cured. If you can get 2 in a row, 2 negative PET-CTs in a row, 98% probability that you are cured of your cancer. Does this mean that we can stop all further imaging after 2 negative PET-CTs? Well, that's what we believe, and we might end up saving money because a lot of our patients end up with 2 negative PET-CTs, and then we don't need any more imaging ever again unless they have clinical signs of recurrence. Now, we don't know whether we can apply this principle to contrast-enhanced CT scans. We only know we can apply it to PET-CTs, and we don't actually know if it saves money in the long run, but I'm thinking it will. Most of this talk is actually about NI-RADS. What's NI-RADS? It's an ACR-sponsored scoring system that is akin to BI-RADS, the familiar BI-RADS used in breast imaging. It's based on that, but it's somewhat more simple than BI-RADS. It's got a 4-point scale where 1 is no evidence of disease, 2 is questionable finding, probably negative, 3 is a suspicious finding that we think is probably evidence of disease, and 4 is for definitive recurrence, biopsy-proven, definitive evidence of progression on imaging, that sort of thing. We really reserve 4 for known disease, definitive disease. We apply this scoring system once at the primary site, once at the neck nodes, and if you did whole body imaging, then you do 1 more for distant disease. Obviously, if you're just doing a CT of the neck, you don't apply a D score. So at the end of my reports, all of my cancer surveillance reports, I have this little code that goes after the impression, and it reads something like P1N2D1. What that means is no evidence of disease at the primary site. The nodes are not totally normal, but probably going to end up being negative and sterilized of disease, and no evidence of distant metastases. That's how I would translate that code. Every single radiology report on head and neck cancer surveillance gets this regardless of modality, although we found it to be most useful in PET-CT. One of the most important concepts about NI-RADS is that the score is tied to your clinical recommendation. If you give a 1, you are advocating for a routine surveillance. If you give a 2, you're advocating for short interval follow-up, close watching, make sure that it truly is negative. If you give a score of 3, you are advocating for biopsy. That's really the most important one. And 4 is go ahead and treat or palliate. Usually we know the diagnosis at that point. That difference between 2 and 3, advocating for short interval follow-up and advocating for biopsy, is critical, because if you're not sure, should I call this a 2 or call this a 3, think to yourself, does this patient need to be biopsied? Would I be willing to do a percutaneous biopsy to find out what this is? Because if the answer is yes, if you think a biopsy is warranted in that patient, you should encode as 3, probably positive, because of that recommendation. Note that there is no equivocal. There's no middle ground where I don't know what we should do with this patient. You have to take a stand as a radiologist and recommend either a biopsy or some other form of surveillance. Now, the surgeon may have additional information, the oncologist may have additional information that may guide them away from your recommendation, but you've got to make a radiologist's recommendation for what is the next step. And you may be surprised how well that is received. Let's take some examples now using PET-CT, because that is where I find it most useful, using PET-CT to show examples of how NI-RADS should be employed. Here's an example of a maximum intensity projection of a PET scan where there is no supraphysiologic FDG activity. That's where you want to use your NI-RADS 1. Sometimes we encounter a familiar artifact that we know from experience does not represent malignancy. This is an example of brown fat uptake. Looks really bad on that maximum intensity projection, but this distribution is absolutely characteristic of this artifact. Another really important scenario where we apply NI-RADS 1 is in patients who had bulky lymphadenopathy at presentation, but then after treatment, the FDG avidity disappeared and they become just normal physiologic FDG avidity. We used to take all of those patients with bulky lymphadenopathy and do planned neck dissections afterwards, no matter how well they responded to therapy, because some 30% of them had not sterilized those nodes with treatment. But now we know that we can use PET to differentiate some percentage of those patients who can avoid that planned neck dissection. It's been really powerful at reducing unnecessary surgery. So for example, here's a patient with a large base of tongue and tonsil primary with bulky lymphadenopathy on the staging scan. And when this patient was treated, there was a complete response in terms of FDG avidity within that node. And we know that even though there's a pretty large residual cystic cavity there, that there's no viability because of the lack of FDG avidity. So we can code this NI-RADS 1. Calcification within nodes is another very reassuring finding on post-treatment imaging, even if the node does not completely disappear. Let's move on to NI-RADS 2. Sometimes you see inflammatory disease in the lung, and it is so clearly inflammatory and patchy that there's no doubt in your mind, there's no chance of it being malignancy, and you could encode that NI-RADS 1. Sometimes you encounter inflammatory disease and you're like, okay, that's probably inflammatory, but it's in a distribution here that corresponds to aspiration pneumonia, pretty classic, but what if it is obscuring some underlying metastatic disease? I'm really not certain. I want to make sure that this resolves. That's where you use NI-RADS 2. Another situation where NI-RADS 2 is appropriate is post-irradiation. Sometimes a normal node that never even had cancer in it will become inflamed after radiation, will become more FDG avid, will enlarge slightly. These are concerning findings, of course, an enlarged FDG avid node, but sometimes this happens just from the radiation itself. So there's a situation, if you believe that it's a radiation effect, but we still want to use NI-RADS 2 in order to pay attention to that in future imaging and make sure that that's not hiding malignancy. Another situation where NI-RADS 2 is appropriate is when you get a partial response on CT but a complete response on PET. Now remember, we really trust that complete response on PET. Here's a patient who has bulky bilateral lymphadenopathy from an oropharyngeal primary, a lot of enhancement in the nodes, a lot of FDG avidity. After treatment, these nodes have almost completely lost any FDG avidity, but they're still not simple on CT. They're not calcified, they haven't gone completely cystic. There's still some areas where there might be some enhancement, so we're not completely confident here. Probably, based on the PET, probably these have been sterilized of malignancy, but we're not entirely sure, so we're going to call this NI-RADS 2. Another situation that can be kind of confusing is when we have bulky disease that has near complete response on both CT and PET. So here's a patient with a large lymph node up in level 2, and after treatment, there is still a little bit of FDG avidity there. It's much smaller. It has much less FDG avidity than it did before, but it's not completely resolved in either of the two modalities. When we first started using PET-CT, we weren't sure whether this was going to represent disease that's about to bounce back because of that FDG avidity or whether it represents disease that is fading away. Turns out it's the latter, and we've learned from experience that these are most appropriately categorized as NI-RADS 2 because 80% of these are going to have been successfully treated. Okay, moving on to NI-RADS 3. One of the most important things to understand about treated head and neck cancer is that once it has been treated, it needs to be gone. Not just a little better, it needs to be gone for us to consider it to be successful treatment. So here's a patient, for example, where there is a bulky primary tumor wrapping around from the tongue base around the lateral wall of the oropharynx. After treatment, that bulkiness is gone, but there is still a lot of FDG avidity and enhancing tissue circumferentially, a rind of residual tissue along the lateral aspect of the oropharynx. That's pretty concerning, so especially in the primary tumor bed, so that probably deserves a biopsy, and that's going to be a NI-RADS 3. We use NI-RADS 3 when there's been an inadequate response to therapy and we feel like the patient would benefit from a neck dissection. A neck dissection is just another way of getting tissue, another form of biopsy. So here's a patient with bulky disease in level 3, and after treatment, it has shrunk a bit, but it's still very FDG avid and it hasn't shrunk down enough. This is really concerning to still see this much FDG avidity. It's the brightest thing in the neck. This patient will benefit from a neck dissection as there is likely to be residual disease in the neck. We have to be really careful in situations where there's no FDG avidity, but there is residual rim enhancement, particularly if it's a cystic or necrotic lymph node. Right? So you've been looking at this picture for a little while now. The concerning lymph node is that one. Let's blow that up. So even though there's no FDG avidity in this node, there is still a lot of nodular peripheral enhancement. Very concerning despite the lack of FDG avidity. Remember, you're using PET-CT as a combined modality. If you're just looking at the PET or you're just looking at the CT and that's what's driving all your decision making, you're not getting the benefit of this combined modality. Here's a situation where the FDG is negative, where the PET is negative. That should be very reassuring to us, but this CT is just so concerning. We're not going to trust the PET. The CT is way too concerning. This needs to be excised or biopsied. Okay, I just showed you a situation where the CT drove the decision making. Now I want to show you an example where PET drives the decision making. Here's a situation where the area of interest is obscured by streak artifact from the dental amalgam. But once you pull the PET out, it's really obvious where the recurrent primary tumor is. Even in retrospect, I really can't see it on the CT, but PET wins the day. This is very concerning and gets a NI-RADS 3. NI-RADS 4 is reserved for unequivocal recurrence. Here's a patient who has a large, aggressive, infiltrative, heterogeneously enhancing mass within the reconstruction flap, tons of FDG avidity. There is no doubt in anyone's mind that this is a recurrence. Even prior to biopsy, I'd be willing to put a NI-RADS 4 on this one. Sometimes even in the presence of a negative CT, you can stare at this picture all you want, but I think no matter how hard you stare, it's really hard to identify these metastases that are evident on the PET. This one is so definitively bony metastases that I am comfortable applying a NI-RADS 4 even in the absence of tissue sampling. Okay, I've shown you some examples of NI-RADS as it applies in PET-CT, but does it work? Can we actually successfully risk stratify patients using this subjective technique? It turns out we can, and these are the numbers that we have for PET-CT at the University of Pittsburgh. It turns out that similar values have been shown at other institutions around the world. For a NI-RADS 1, for the first surveillance scan, at the conclusion of therapy, a NI-RADS value of 1 corresponds to 90% negative predictive value. 90% sure that that patient has been cured. That's really powerful. If you apply a NI-RADS 2, it's still pretty good. You're 80% sure that that patient has been cured, 80% negative predictive value. NI-RADS 3, the positive predictive value of NI-RADS 3 is only 60%. That sounds bad, but you're just going to subject those patients to biopsy. Most of those biopsies are going to be positive. If you knew there was a 60% chance that a biopsy would be successful, you'd perform that biopsy for sure, and that's what NI-RADS 3 gets us. NI-RADS 4, 100% in actual practice, so we are effectively reserving that for scans that we are absolutely certain on. So NI-RADS really works. It's truly effective in the care of patients. But there are some remaining questions that need to be answered. For example, if we do find a recurrence earlier in the patient's surveillance, does that actually improve their lives? Do they actually have less morbidity from their further treatment? And do we save their lives? We don't know the answer to that. Is there an optimal surveillance strategy? I kind of laid out what we've been doing at the University of Pittsburgh, but I'm not claiming that that's the only answer. And these are expensive tests. PET-CTs are expensive. How do we balance improved detection versus the cost of these expensive tests? When can we stop surveillance imaging? A good surveillance program will find everything within 2 years. Can we shave that off a little more? Can we stop at 18 months? Does a different surveillance algorithm require us to take it out a little further? And then PET-MR. Should you buy a PET-MR? Very few of them have been sold anywhere in the world. Most people are comfortable using their MR scanner and their PET-CT scanner on the same patients. Is it worthwhile to collapse those two studies into a PET-MR? I'm going to conclude with a summary slide that is the scheme we use for PET-CT surveillance of head and neck squamous cell carcinoma at the University of Pittsburgh. We start with a PET-CT scan 2 to 3 months after the conclusion of therapy. That might be surgery. Usually it's chemoradiation, either preceded by surgery or as first-line therapy. But 2 to 3 months after the conclusion of therapy, we get our first scan. And what happens to the patient after that? The surveillance algorithm for that patient depends on the results of that first scan. So this is a nuanced, personalized surveillance regimen. If that first scan has a NI-RADS value of 1, if the maximum NI-RADS number on that scan is 1, we get a follow-up PET-CT in 6 months. That's an elongated follow-up. That's longer than we would normally do a routine follow-up, but we know that most of our recurrences occur at 6 months, 5 to 6 months, so this is a good time point for a follow-up if the first value is 1. If a second one also has an NI-RADS value of 1, you've got 2 consecutive PET-CTs that are encoded NI-RADS 1, 98% certain that the disease has been cured and no further imaging is necessary. We pull these patients out of our imaging surveillance protocol, our imaging surveillance regimen. Not all of the surgeons and oncologists are comfortable with this. These patients occasionally will get an additional scan, but in the absence of clinical findings, the science suggests that you can stop imaging these patients. What if the first scan is a 2? Well, if the first scan is 2, then we follow our routine surveillance with follow-up imaging in 3 months, and the patient gets plugged back in with that second scan back into these same 4 categories. So if the second scan is a 1, then we move to this 6-month follow-up, for example. If the NI-RADS is a 3, then we biopsy as is appropriate for NI-RADS. If it's 4, we treat or palliate that patient. So often we need to biopsy to prove the NI-RADS 4 category or for experimental therapies, but all of these patients move on in their treatment. This is how we do it at the University of Pittsburgh. This is how we employ NI-RADS in actual clinical practice. So that is a summary of surveillance imaging, the hows and whys, and with a real focus on NI-RADS. I'm a big believer in this system. I think that everyone should be using it. I think that if you try it out in your hospital, you'll find that your surgeons and your oncologists are going to be big fans. It makes it very clear how certain you are that there is tumor left behind in these patients and what you think should happen next. In combination with your participation in a multidisciplinary tumor board, this is a really, really powerful tool.